recording. All right, so I'm excited today to be with Ashish George, and he's going to be talking to us about policies and some of the work he's been doing. And we're going to talk about how he sees trauma and resilience in the people that he works with, and some policy priorities in North Carolina. So Ashish, if you don't mind to introduce yourself and tell us whatever you'd like us to know about yourself, and then we'll start on some of our content for today. It's good to have you with us. Thanks for being here.
Yeah, thank you, Denise. Thank you for having me. So I'm Ashish George. I'm the Public Policy Director and Psychiatric Advanced Directive Specialist for NAMI, North Carolina. NAMI is the National Alliance on Mental Illness. We have chapters across America in every state. And I am the public policy guy for North Carolina. We also have affiliates throughout the state, 23 or 24, I believe at the moment. And so I've been in my role since January 2020. The two sides of my work are lobbying. I'm a registered lobbyist, technically. So I work with legislators, policymakers, other coalition allies, like the National Association of Social Workers, North Carolina, American Foundation for Suicide Prevention, groups like that, Disability Rights North Carolina, to see better policies implemented. And then I also work on PADs, Psychiatric Advanced Directives, and those are legal documents you can fill out ahead of time so that in the event of a psychiatric emergency, when you are not able to make decisions for yourself, you can nonetheless have your wishes documented in a legal form that doctors are obligated to consult and follow. So that's just a little bit of an introduction. Denise, should I keep talking about policy issues, or would you like to chime in?
This is kind of off topic, but let me ask you a question, because I teach at the social work department at AP, and I do some macro stuff. And people frequently are like, do people actually get paid only to lobby? And I'm like, I think so, but I don't know how in the world that happens. So just for my own clarification professionally, there's actually paid positions where people, that is their job to go and lobby with legislators. I know this probably seems like this should be common sense, but your job is to go and network and lobby with legislators to get policies passed. You mind to talk about that just even for like 60 seconds, what that looks like?
Sure. So typically, if I want to meet with someone, I will contact their legislative aide, and we will schedule a meeting, and I'll talk about some item agenda. Like, for example, Sydney Batch is a very strong advocate. She's a senator from the Charlotte area. So she has helped us with our response to the Fayetteville Observer articles that were published late last year about the abuse of teenagers in psychiatric facilities and institutionalization. So lobbying often involves trying to see where legislators are in their party and understanding how much influence they wield. Obviously, someone like Phil Berger wields more influence than a Democrat who's just been elected to their first term. And because we have divided government in North Carolina, lobbying is much different than it would be in, say, California, where you have one party controlling both the governorship and the assembly, the legislature. And yes, I am paid to be a lobbyist, but that's not entirely my job. I make presentations like this one. I meet with journalists. I just had an interview with someone from the Charlotte NPR affiliate. I make presentations to young people. And of course, there's the PADS work that I mentioned a moment ago.
That's so interesting to me. Thank you for explaining that. Now maybe I can answer their questions a little bit better when they ask me about that. Because some people, I feel like a lot of times we get into like policy change and policy work by accident. That's how it's been for me. I've kind of stumbled over it in my regular day job. You'll run across policies that don't seem to benefit the people that they impact. And so you work to change those specific things. But we live in a really small community, so I just don't have a lot of awareness about how that works when that's part of your job role. So thanks for explaining that to me. I know we want to cover things like Medicaid expansion and psychiatric directives and the work that you do in schools. I know this is probably, a lot of us know what NAMI is, but can you talk a little, one of the things we like to cover is how you see trauma and resilience in the people that you work with or the people whose work you're impacting. So before we get to some of those specific things, can you talk a little bit about how trauma may impact the populations that you feel like you're serving?
Yeah, so the word trauma comes from the German word for dream, Traum. So a lot of times when you interact with people, their trauma feels like something that happened in a past life, but it's nonetheless, enveloping them, surrounding their actions, surrounding their thoughts. So we deal with a lot of people who have overcome or are having an ongoing effort of overcoming, mental health challenges. And of course, for a lot of people, those will be lifelong challenges, which is why I do the PADS work, right? To help them prepare for hospitalization or institutionalization. And we see everything from schizophrenia to bipolar disorder to people who are, not really sure about how to self-diagnose, because that can be a problem. All the research seems to suggest that early interventions in teenage years or someone's early 20s can make a huge difference in softening future mental health crises. So our goal is to, ultimately prevent trauma from even occurring, right? That's the ideal goal. That can be difficult, of course, because we can't control what someone's home life is like necessarily. We can't control how they relate to romantic relationships, friendships, etc. So people will get hurt in life. We all get hurt in life. But trauma is something unique that can only become worse if you have no one to talk to. And we see in public policy that responses to trauma can often be traumatic themselves. Like involuntary commitment rates in North Carolina have skyrocketed in the last, about 8 or 10 years. And that's really a bad sign, I think. It reflects poor resources in this, like I was saying, in a young person's life, when they are most likely to benefit from intervention. It reflects a certain hastiness, I think, in institutions and responders to immediately point to involuntary commitment as an issue, as a response to people who are struggling. And ultimately, it's not a good way to help with mental health recovery, because from my perspective, and I think from most people who are on this call, from our perspective, we want people to be in charge of their own mental health journey, which includes setting progress benchmarks of their own, going in and leaving at their own leisure. I mean, with the doctor's, advice, but still. But involuntary commitment is when you are perhaps traumatically, again, to use that word, forced by police or transportation of some kind into a facility against your will, and there you can quickly find yourself surrounded by very territorial, let's be honest, doctors or nurses. There's no need to romanticize the medical system we have, right? And you can feel like you're being barked at rather than talked to. And so when you see things like that, you wonder whether or not we as a society are equipped to even process what people are going through. And of course, lots of people don't have any mental health treatment at all until they are in prisons or jails. That's their first encounter with the mental health care system. And at that point, prisons and jails tend to harden people, tend to exacerbate problems, tend to make it harder to find housing and employment later on. So it can be a vicious cycle. And I think my number one goal, or one of my number one goals as a policy lobbyist, is to work so that institutions play less of a role in controlling people and work more towards getting people support as they are becoming who they are as adults and young people. And even later in life, when they're on the journey to recovery, not insisting that they be bound by psychiatric facilities or police interventions.
Yeah, that makes sense. There was a question in the chat about how you got into this work. We didn't talk about you sharing that with us, but if you don't mind to talk a little bit about how you came to this work.
Sure. So I went to I grew up in Greensboro. I went to Davidson near Charlotte for college. I worked there for a while. And I worked for a while in India, where my family is from. And then I was, after the 2016 election, like a lot of people, I was thinking about how I could try to make a difference in the world, and how I could plant roots at the same time. And so I was always keeping my eye open for a job back in the US. And I saw this posting after I moved back, and I was just like, yeah, this fits perfectly with my own experiences as a disabled person. I'm in a wheelchair, and as a a lifelong North Carolinian, someone who understands that the state is very diverse and very challenging. Someone who grew up without much money like me, kind of has a perspective on how a lack of resources can seriously alter a life. And NAMI, North Carolina, makes a big effort to be diverse. We can do much better for sure. But we are definitely always interested in trying to get a diverse array of perspectives. And in the job description and in the interviews I had, that was clearly a priority from our executive director, Gary Kreitz. And so that's what drew me to the work. And it's been very fulfilling so far. It's a very supportive work environment. And everyone I meet in allied organizations has been so motivated, so knowledgeable, and so compassionate. It's the best job I've had so far in my career.
Oh, that's cool. I wrote down the line that you said, an awareness of how the lack of resources can seriously alter a life. That it's beautifully spoken, although I think it can't even begin to describe the depth of what you're talking about, but it was very eloquently said. So I wrote that down. I'm going to think about that later. So thank you for sharing that part of your story. I'm going to kind of let you, you mentioned three things: Medicaid expansion, school resources, and psychiatric directives. Whichever one of those you want to start with.
Yeah, I'll start with Medicaid expansion because that's, often uppermost in my mind. There was recently a Politico article, I'll put it in the chat box, about how up to 15 million people nationwide could lose their Medicaid coverage in the coming months before 2022 ends, because during the pandemic, states were not authorized to kick people off Medicaid, but now you're seeing audits kick into gear. And when people are audited about their eligibility, of course, a lot of people will have incomes that are technically too high. And so they are going to be kicked off the Medicaid rolls. In the Politico article that I just put in the chat box, what it describes is basically a series of events that's going to lead to states, kicking people off their Medicaid benefits without people even being prepared to fight for them, right? They're just going to, quietly be taken off Medicaid rolls, and we need to prepare for that. I'll be attending the legislative breakfast on mental health on the 26th of this month, and I intend to talk to several people about this, including DHHS, the Department of Health and Human Services. But in Utah, for example, this article talks about this. In Utah, they were prepared. They said, we are worried about people losing Medicaid benefits. Let's do our best to reach out to people. Let's do our best to make sure that eligibility covers as many people as can be covered. Let's make sure that the state can get people the help they need. And it was still kind of a problem. It was still, even with that level of preparation, a situation where you had quite a bit of loss on the Medicaid enrollee list. And in North Carolina, unless we're prepared, it's going to be just as bad. Regardless, unfortunately, people are going to lose their Medicaid benefits. The best we can hope for is to minimize the number who do. So there's kind of an irony, a dark irony in the fact that my organization and every other organization we're allied with is pushing so hard for Medicaid expansion. And meanwhile, we're seeing Medicaid contraction on the horizon. So Biden has expanded some emergency provisions until April. But after that, I expect this problem to really kick into high gear. And I think that's quite unfortunate. If Medicaid expansion, on the other hand, were implemented, and we've recently seen some Republican movement towards discussing that more openly, up to 500,000 or more North Carolinians would be eligible for Medicaid. And that includes, of course, children. And, we were talking about how early interventions can make a big difference in mental health outcomes. So if let's say a 14-year-old becomes eligible for Medicaid because he's part of a family that's eligible for Medicaid, and he or she is having schizophrenic symptoms, struggling at school, struggling to integrate into social networks, this could be a huge, game changer for him or for her. So Medicaid expansion is quite literally a life or death issue for so many people. It can keep people out of the carceral system, out of jails and prisons. It can lead to better employment opportunities, better friendships, better romantic opportunities, and all of that can lead to better long-term life outcomes, right? So I really focus a lot on young people in my work. I speak sometimes in my capacity as public policy director to high school students, college students, aspiring social workers in their 20s. It's really key that we keep in mind that Medicaid is, it shouldn't be a political football because we're one of 12 states that is yet to expand Medicaid. By the end of the year, we might be one of 11 states because South Dakota is having a referendum that might lead to Medicaid expansion. So that's where we are right now with Medicaid. I'd recommend everyone read that Politico article. And if you know someone on Medicaid who might be audited and have their benefits taken away, please let them know as well. I'll pause there. It looks like you have a question, Denise.
Well, I was just thinking it's so difficult already to get, so I work at school in a K-8, and I think most of us on this call, most of us work directly with children and adults. And it's so difficult already to find services for children. I remember when I first started this job 25 years ago, we had case managers and one-on-ones and group homes and plenty of psychiatric beds, and you could see a therapist every week if somebody decided that's what you needed to do, and have just watched since then things continue to be cut and cut. And so currently it's so difficult to find for a child a therapist who accepts Medicaid, and I understand all the reasons why, and has an opening for a new client that I agree with your statement that it really is a life or death issue. And so I didn't realize we were only one of 12 states who had not yet done the Medicaid expansion. So I appreciate you talking to us about that. Anything else that you'd like to add about that?
Just that, Medicaid helps the most vulnerable among us. So when we think about why we have these government services, it's because, well, one, no one deserves to suffer, right? Everyone deserves to flourish. But number two, it's not healthy to live in a society where you have an underclass of people who are just caught in a cycle of poverty and caught, in systems that they aren't in control of, right? Like 1 out of every 5 American children struggles with food insecurity. So when you have children involved, that it's not just a sentimental question. It's a question of what kind of society do you want to live in? What kind of future generations do you want to have in charge of power, in charge of our schools, and just living among us, right, as neighbors, as friends. I'll move on now to school resources. So, what we really want to see is schools not be on their own. It really does seem like, to a significant extent, the legislature is happy to say schools need to implement mental health policies to identify people with suicidal ideation. They need to have plans to help depressed students, et cetera, et cetera. Well, okay, fine. I agree. But you can't do that without funding school resources, right? You can't just turn a math teacher into a psychiatrist. What you need to do is have more counselors. You need to contract the ratio between counselors to students. So I don't want to see a high school with 1,600 students and just 2 guidance counselors. Like, that's ridiculous. So school resources for us is, again, a matter of intervening early and also preparing people. So let's say you have a child, you're a mother, you have a child with severe schizophrenia. He or she is 16 or 17, toward the end of high school, right? They struggle with social relationships. They struggle academically, but they're not, of course, bad people. Of course, no one struggling with mental health challenges as a child, as a minor, is a bad person, right? But then, when you leave high school, what do you do? What do you do if you're struggling with employment prospects, if you're struggling with housing opportunities, if you as a mother are, worried about your own health, like you're not going to be there forever for your child, what do you do? I think schools need to do a better job of preparing, teenagers and parents in situations like that for integrating themselves into, mainstream society. So this is slightly related, but I'll bring it up here because it was such a big part of NAMI's work at the end of 2021. I think most people here are familiar with the Olmstead plan, but I'll summarize it in case you aren't. So in the late 90s, Ruth Bader Ginsburg wrote an opinion for the Supreme Court saying that people in facilities that separated individuals with intellectual cognitive disabilities from the mainstream population needed to integrate that population into living alongside non-disabled people with all possible speed. So it was a decision disability rights activists have hailed as, in some respects, comparable to Brown versus Board of Education, right? The idea is integrating people with challenges, in this case, intellectual and developmental disabilities, into the mainstream population, taking them out of institutions. Well, North Carolina did a lousy job, frankly, of doing that for many years. And a lawsuit was brought against the state, I think by the Justice Department. And then in around 2010 or so, this Olmstead settlement said, all right, North Carolina, you need to really get with this, shape up. So North Carolina has been, since then, trying to figure out a way to implement the Olmstead ruling, to get these people with these disabilities integrated into mainstream society efficiently and compassionately. Well, DHHS published a plan for this in late 2021. And Disability Rights North Carolina, the National Association of Social Workers, us, lots of other groups took a look at the plan and said, this is barely a plan at all. It's very vague. It doesn't tell us how specifically we're going to get from point A to point B. It doesn't have any allowance for cross-departmental coordination. So, how does housing coordinate with transportation, and how does transportation coordinate with education? All these things to help the settlement happen more efficiently. So we responded together and individually as groups, and offered a constructive critique. But unfortunately, it doesn't look like it really took hold. It seems like Olmsted is kind of still far from implementation the way it needs to be. And again, I bring this up because the people who are not in the spotlight, right? The people who are young and maybe neglected or ignored in schools, the people who are in facilities and have disabilities of various kinds, the people who are most at risk of falling through the cracks of our patchwork social safety net, these people are the ones that NAMI North Carolina wants to help the most. And yet in public policy, we're seeing a lot of shortcuts being taken, right? So honestly, I brought up Medicaid a few minutes ago. Honestly, I think there would be a few people in the legislature, let's be real, who would be happy if there were fewer people on the Medicaid rolls, because their goal is not to see human flourishing. Their goal is not to see the maximum number of people helped out by government services. Their goal is to streamline government so that it's small, right? So that it doesn't, have to do much work. So there's less money being moved around. And that's really unfortunate, I think, because we're all in this together. And, it can't just be that prisons, police, and jails, along with some psychiatric facilities for people who are really struggling, are the only things that are funded. That can't be the case. We have to fund people in communities with resources like guidance counselors and Medicaid and 988 implementation, which I'm sure you've been following. So yeah, that's just where I see the landscape right now. And of course, COVID has taken a lot of oxygen out of the room at all times in terms of policymaking, but it should be a wake-up call that a lot of people have been suffering for a long time. And when the next pandemic hits, or if there's another COVID strain that causes, even more suffering and death, we need to be prepared for people who are not equipped, right? Who don't have a wide support network in their personal lives.
So when you talk about supporting schools, can you give me an example of, do schools actually contact you to come in person and provide services, or how does that whole process work, and what kind of supports are you providing to them?
Well, we do have a NAMI program where teenagers can address other teenagers about mental health struggles. So that is a program we implement free of cost in various schools. I'm not in charge of programs, so I don't get personally contacted about implementation like that. But I do know it's something we offer. When I talk to high school students or college students, it's because someone has reached out. Like, I was part of an NC State panel about faith and mental health. And you didn't have to be a part of any faith tradition per se to take part, but as a NAMI staff member working on public policy, they thought I would be good to have on board. And, I did my best to try to connect a lot of these issues like I am now. What I hear from a lot of young people is a certain timidity, to be honest. They don't know what the future might look like because everything has been disrupted by COVID. They've already been spending too much time in front of screens, and then their learning became screen oriented. Like, that seems pretty bad to me. So when we talk about school resources, we're talking about government provision primarily. Organizations like NAMI should not be tasked with filling in those gaps, right? That would be a terrible sign, because as talented as my coworkers and I are in various respects, we are not qualified for helping 100 counties in North Carolina deal with their diverse student populations.
Yeah, that makes sense. Anything else you want to add about work in the schools before we move on to psychiatric directives?
No, I would just add that, we're not going to know the effects of COVID masking, distance learning, the isolation of the pandemic on young people until many years from now. I mean, all of us can speculate that it's been horrible because we're seeing that with people we know. Like I see that in my niece and nephew. But the full extent of the damage is probably going to be worse than any of us could even imagine. Like we all know it's bad, but I think it'll be even worse than that. Because, friendships matter a great deal in adolescence in terms of helping teenagers find their place in the world. And how do you make friends over a screen or via text, right? Like I guess you can do it, but people need to be touched. People need to make eye contact. People need to laugh together. And that's harder to do, of course, from a distance or with a mask on. But yeah, that's just, those are just my 2 cents.
No, I agree. I have an 18-year-old who spent the last 3 years of high school in COVID. And the first spring that it happened, not that she had a great relationship with her teachers and really enjoyed going to school. And one of them finally emailed me and was like, we've emailed Grace like 10 times. Asking where she is. She's not participating in class. And I went to her and, said, tell me about this. And she said, well, what I've learned is it's not that school that matters to me. It's the relationships with my teachers. I care about my teachers as people. And she said, all I have to do is not open my laptop and they don't even exist when it's virtual. And I thought that was really interesting that you just keep it closed and it shuts down your whole connection to the education world. So we definitely saw that firsthand. And while I do think they build plenty of relationships, a plethora of relationships virtually, the quality, she and I talk a lot about how the quality is different and interaction is more superficial. And then there's not that extended conversation where you are going back and forth about deeper kinds of topics. So I definitely agree that the quality is very impacted for sure. All right, so psychiatric directives, that's one of the things you wanted to talk some about. What can you tell us about that work?
Yeah, so psychiatric advance directives are useful for everyone, I think, because at some point, if you live long enough, you are going to be in a state where you are not capable in the legal and medical sense. Capability is a legal and medical term. It means understanding your circumstances, understanding what doctors try to explain to you, and being able to respond. So if we live long enough, all of us will reach that point where we lack capability. For people with mental health challenges like schizophrenia, just people who have trouble or will have trouble distinguishing reality from hallucinations or using language well, that can be a real source of stress, because we all know, like I was saying earlier, how psychiatric facilities can exacerbate some problems if doctors are territorial and insist on doing things their way when it comes to treating people who are incapable. So psychiatric advance directives, there are 2 parts to the form. There's the advanced instructions for mental health treatment. This is where you can write down how you feel about various things like hospital admission, electroconvulsive treatment, medications. You can make a long list and say, well, this medication causes me to grind my teeth. I would really prefer an alternative if possible. You can say this medication has worked well for me in the past. If possible, give me this medication. The second part of a psychiatric events directive is the healthcare power of attorney. This allows you to appoint someone to make decisions for you. If you are incapable, it can be a brother, a spouse, a sister, a child, if they're over the age of 18. And they can be your advocate, basically, in the event of hospitalization. And so what's really important here is the fact that you're extrapolating based on past experiences and drawing on research you do, not in a quick, like 5-minute Wikipedia search, but through several, days or weeks of conversation with your loved ones, your medical professionals, your family members, to decide what's best for you. And the reason it's important to have those conversations is because you don't want family members to be confused about what you would prefer, right? We've all seen cases in the news where someone has had a physical condition that has required family intervention, and the family members have disagreed, like the Terry Schiavo case from the 2000s, right? Remember that, where a young woman was in a persistent vegetative state. Her husband wanted to remove her from life support. Her parents disagreed. It was very, very bitter. It made national news. So you don't want something like that when it comes to mental health treatment, right? You don't want people in your family to disagree. And so I make these presentations about what is involved in a psychiatric advance directive and how it can help people, to doctors, to nurses. I'm trying to present more to people who have mental illness. It's a catch-20. It's a bit hard to reach the population that is most in need of this information, ironically enough, because they are the ones who are perhaps the most isolated and the least likely to find out about these trainings. So that's something I'm working on. I present to hospitals with 3-way contracts, hospitals that have connections to government providers, as well as other psychiatric hospitals in North Carolina. And so all of this has been useful. I hope that soon we can get more people to think about how completing a PAD is useful, not just if you're like at a stage in your life where you're approaching retirement, or your kids are grown and out of the house, but also if you live by yourself and you're relatively young, if you've struggled with mental health challenges, like that's a prime range, a prime audience for these presentations. Because being alone is terrible for various reasons. Being alone with serious mental health issues is even worse, right? Because it can lead to a lot of challenges that you don't otherwise have to deal with, right? So Americans are lonely. Let's face it. Like 1 out of every 4 Americans say they don't have a single confidant in the world, which is bad news both for the development of widespread mental health issues and for treating those issues, when people don't have someone they can rely on to be their advocate. So yeah, if any of you would like more information about PADS or more information about anything I'm talking about now, I'm going to put my email address in the chat box. Please get in touch. Yeah.
We talked, this is making me think of, I didn't tell you we're going to talk about this, so I apologize ahead of time, but this reminds me of a lot of the conversation we've had, both in Wednesday conversations and just at WCCI in general, about the stigma of mental wellness or mental illness. And I know that's a big part of NAMI. Mike Tanner and I talk, or I hear him say, we have conversations about stigma. Any thoughts that you have on, because a lot of times we're talking in these Wednesday conversations, somebody will say, well, I'm trying to help support someone I know that has trauma experience or struggles with mental wellness. What's some tips about how I can do that better? Any tips on how to, especially when you're talking about 1 in 4 say they don't have a single confidant in the world? That kind of shattered my heart a little bit. But any tips on reducing stigma or being a strong support system for someone who struggles with their mental wellness?
Sure, I would say if you have young people in your life, as an aunt, as a mother, as a grandmother, be open about your own challenges. I know that's hard and easier said than done, of course. But I try to be that way in my own life with the young people I know. I struggle with depression. And I think the first thing that can do is just make it seem more normal. Um, and there's definitely been improvement. When I was in college in the 2000s, I graduated from college in 2007. I feel like people talk a lot less about mental illness, a lot less about mental health issues. It's really in the last 7 or 8 years that you've seen far more open discussion about mental health issues. Celebrities open up. It's become more normalized to go to therapy. Not that it's easy to get a therapist by any means, but it's become more normalized to go and to even be on medication. So be open in your own life with people you know. Make sure that when you talk, you emphasize that no matter how bad things have been in the past, things can get better. So, just sorry. Phew, sorry. Thank you. I think there's a lot of shame about past failures, like, my mental health issues ruined this relationship. My mental health issues ruined this job opportunity. My mental health opportunities led to this run in with the law. Yeah, I mean, all of those things can be devastating, but growth is it springs from unusual circumstances, and especially when you're a young person, your idea of like what normal looks like can be far too narrow. Narrow is a lie, right? I think most people on this call know that normal is a lie. But when we have the opportunity to let young people know that adults are mostly faking it if they pretend that they're normal, then that goes a long way towards letting teenagers find their footing, right? And we have a blog where people share their stories. I've shared my story. If any of you have something interesting about your mental health journey, please get in touch. We're happy to publish pieces by people outside our staff. And the goal of that is to make people understand that mental health issues can come from diverse circumstances. You can be rich, you can be poor, you can be in between, you can be Black, white, Hispanic, you can be gay, straight, transgender. Mental health issues are not, they don't discriminate, right? They're open to everyone. And thankfully, I think we've seen, a lot of celebrities open up about this, like, Kevin Love from the NBA. He's been very vocal about his mental challenges. Kirsten Dunst, the actress, has talked about her depression. And so Pete Davidson, the comedian, when you have people open up who are very different from each other and seemingly have it all, right? Money and status and primetime TV appearances, you think like, well, their lives are perfect. But no, it turns out that you can deal with mental illness and still be functional in other ways, and yet not feel miserable on the inside.
There was a comment in the chat that from Karen actually, who said one thing that helps is community inclusion. I've heard Mike Tanner talking about this a lot as well, including all and letting them know that they're okay and working with the community to accept more diversity. I saw the most interesting thing yesterday somewhere. It said, we work so hard with children with differing abilities to assimilate them, to give them skills to assimilate into society, and don't spend nearly that much time preparing society to interact more effectively with them. I thought that was an interesting perspective. So definitely community inclusion for shattering stigma and including all. You mentioned a blog. Is that something that you're able to put in the chat for us, or how can we find that?
Yeah, I'll link to the blog. And if you look through the past entries, you'll see an entry I wrote. And I'm currently working with someone who reached out to us about potentially contributing to the blog as well. So if anyone on this call would like to contribute, let me know. You can read some of the prior entries and get a feel for what we're looking for. It's like 800 words, so it's not very long. Yeah, I think, one of the things we really do well with at NAMI is being a statewide organization. So Michaela Cardona, my colleague, who's in charge of affiliates, she does a great job of reaching from Manteo to Murphy, as they say, the west to the east. East to west, I guess. Manteo is in the east. I live in Greensboro. I grew up in Greensboro. It's the third biggest city in North Carolina, full of colleges. The downtown is resurgent. But then, I've met so many people who live in parts of the state without, a Walmart and without a McDonald's, with 3 traffic lights in the whole town. You can drive miles and miles and just see horses and cows, right? So when you think about people who are isolated, people who live in more rural parts of the state, you understand how difficult it must be to deal with mental health challenges and not be near clinicians or practitioners. We assume, I think, or it's easy to assume, I should say, if you live in Raleigh or Charlotte or Greensboro or Chapel Hill, that whatever challenges you're going through, you'll always have help nearby if you want to seek it out. But that's not the case for everyone in North Carolina, right? We're not Vermont, right? We're not a small, homogenous state. We're a big, diverse state with all the messiness and opportunity that entails. So with the 988 implementation, for example, we've had a lot of comments from more rural supporters who are worried about whether or not it'll work as well for people who are not so close to an urban center or a college town. And that is a valid concern. And, 988 is going to have some kinks in it. But I really hope it works out because there's so many, like I said, there's so many people whose only connection to mental health support right now is the internet. They have no face-to-face connection. And it's not just because of COVID, it's because of rural isolation. And so take all the problems we've been discussing today about young people, about lack of resources, lack of transportation, Medicaid, et cetera, and multiply that by, let's say, 5 or 10, based on how rural, how isolated a community might be.
If someone doesn't know on the call, may not know what 988 is, do you mind to take a minute or two and explain what that is?
Sure. 988 is a hotline for people in crisis. I'll provide a link in the chat box as well. And it's due to be launched in July. This is it's a number that'll lead to people being able to answer, call in anytime, at any time during the day, and have someone to talk to about resources, have someone to respond through mobile crisis teams, and have somewhere to go. Those are the 3 goals of 988. I'm putting the link in the chat box.
Okay.
So, let's say again, you live in a rural part of the state and you are frustrated. You are imagining that it would be better not to be alive at all. You should be able to call 988, ideally, when it gets up and running this summer, and go through those 3 steps, right? Someone to call, somewhere to go, and then someone who can help you out. It's like 911 for mental health crises. That's an easy way to describe it. Except the police will not be involved. By the way, I hope that goes without saying. If you know someone in a mental health crisis, don't call the police, no matter what you do, right? Call someone like 988, call NAMI's helpline, call the National Suicide Prevention number, but police are not trained to deal with people in mental health crises. And frankly, they often make things worse.
When you had mentioned way back at the beginning of the call that even though we're doing a lot of work in schools now with trauma-informed practices and responding to mental health needs, that still is not being trained in educational programs for the most part. So a lot of what teachers are learning when they come into teaching is after they've already graduated in the buildings where they are employed, depending on how much the system that employs them wants to emphasize that. And North Carolina mandated some mental health training this year for educators, but it's like 6 hours and really doesn't even give you the basic tools you need to be able to respond. So I know in our county, that's something we're working on, but I'm sure that's not true for every county. And I'm guessing that 988, so for example, in our county, we have a mental health crisis line, and I imagine in bigger cities as well. So was this created with the thought of those more rural secluded areas who don't necessarily have a crisis line, or was that not something that they were attempting a barrier they were trying to address?
Well, it wasn't created with the intention of ignoring them, obviously. I don't think it was specially designed for people in rural areas. I think it was primarily just that a need was seen, a need for a number that people could call and have a way to process their very intense, very overwhelming emotions, their emergencies. And 988 might incidentally be of particular benefit to people in more isolated communities. I'll be interested to see the data collection about 988 calls. By the way, the chatting and text service has been operational since December. What a very rudimentary form of it. But the 988 hotline has not been fully operational. I'm putting the helpline, the NAMI helpline number in the chat box. And that's not open all day. That's just during business hours, Monday through Friday. But my colleague Virginia handles that, and she's very good. So if you or anyone you know needs some help, please get in touch. But yeah, I mean, I've never lived in a rural part of the state, so I am, in many respects, learning secondhand what it would be like to have a mental health crisis in let's say Buncombe County, far from Asheville. So I think that's true of everyone or not everyone, but many people in North Carolina who spend their formative years between Raleigh and Charlotte. Raleigh and Charlotte, that slice of the Piedmont on I-40. It's very easy to kind of be in a bubble. Anyway.
Yeah, no, that makes sense. Well, as soon as I said we live in a town with the crisis line, I remembered that last week somebody wanted the crisis line, and I'm like looking around. Well, I have magnets somewhere. I don't know that by heart. It's something that I have to go to effort to look for. So definitely 988 would be a much easier thing to remember to be able to get help more quickly. So if anybody has any questions or comments for Ashish. I wrote it down at the beginning because I have to do things phonetically. Ashish. You're welcome to put those in the chat. I was going to see one more thing I wanted to ask you was, we talk a lot about how to stay well and how to create resilience in ourselves. We all know the list of get enough sleep and drink enough water and try to, get exercise when you can. But do you have any tips or thoughts about how to stay well?
You hit the major ones. Sleep at least 8 hours a night if you can. And if you're having trouble sleeping, please see a doctor or a pharmacist or someone who has some medical advice about that, because not getting enough sleep can weaken your immune system. It can make you sick. All of us are always thinking about getting sick, of course, because of COVID. So don't get sick. Don't lose sleep. Don't worry about work primarily. Like America teaches people to be productive at all costs sometimes, and I'm including myself in that. Like sometimes you just need to stare off into space like a cat, and that's the best thing you can do for your mental health, right? They have it figured out. Cats do. I firmly believe this. I'd also recommend getting sunshine every day, making eye contact with people outside your house or apartment every day. I know COVID can be scary and we're all still worried about getting infected, but you know, there are different kinds of health, and physical and mental health have to be balanced too. Our brain produces certain chemicals that we really are worse off without, including oxytocin, which is produced when you touch someone that you care about. So even if, you know, see someone, if you have someone in your life who's willing to touch you and be touched by you, I don't even necessarily mean romantically. I just mean touch, platonic touch, a dog's touch, a nephew or niece's touch. All of those things can, you know, be good for your mental health, be good for your immune system. So yeah, think about that, and trust your body. If your body says, I feel bad, that's probably because it feels bad, right? It really is missing one of these things: sleep, touch, sunshine, and of course, food, good food. So eat well. I know if you live alone, as I do, it's hard to prepare meals sometimes. All right, go to a fast food place. It's okay. Like, no shame in that. Even that minimal interaction with the person behind the window is something, right? Yeah, be kind to yourself.
Karen's adding some things. Oh, sorry. Karen's adding some things about their peer support warm line, available anytime, any day if you're feeling isolated, alone. Talking to a confident self-care, self-help, and NAMI support group, such as peer-to-peer, and being kind to yourself, which I definitely can relate to. Well, we're nearing 1 o'clock hour. We so appreciate you spending your time to talk with us about Medicaid expansion and school resources and psychiatric directives. School is only one of those I spent a lot of time thinking about. The psychiatric directive is I'm going to be thinking a lot about that. I've got relatives who are getting older and have had struggles with their mental wellness. So anything you'd like to say? I will copy and paste to Ashish. Oh my gosh, my brain later. So he can read it when he has time. And let me just mention that this is our last live Wednesday conversation. Christelle had the brilliant idea to start back at the beginning with the recordings, on Wednesdays, and send them out so that for those of when we miss things, we can go back, or some of our favorites we can see again. So we'll be doing that. Thank you so much for being with us today. I'm going to turn off the recording.